Assalamu alaikum and good afternoon, ladies and gentlemen. I would like to thank the scientific committee and the chairman for inviting me. And I'm going to talk about updated guideline management. This is the outline of my presentation. And Dr. Jamila, in her excellent talk, have put the ground for my talk as well. When we are selecting the antivirals or the immunomodulator therapy, the different therapeutics, there are three important considerations: severity, phase of illness, and who is at risk of disease progression. This slide was shared in Dr. Jamila's talk. When we talk about severity, there are 4 or 5 stages. There are therapeutics for mild, moderate, severe, and critical. Also, when we talk about phases of pathogenesis, we know early into the infection, we have the viral replication. And then as the time progresses and patient progress into critical illness, there is the hyperinflammatory phase. Whatever works in first phase will not work, might not work in the subsequent phases. In addition to that, in the pathophysiology that was shared with you in the earlier presentation, there was also the cascade of coagulation. So that's why in the initial phase, we use antivirals, and in later phases, we use immunomodulator therapy. And there are also the monoclonal antibodies that should be used as soon as possible as well. So different therapeutics are available, and it's very important to select the correct therapy when you are seeing a patient. Risk of progression, we talk about individuals with chronic diseases as well as comorbidities, and these were listed as well. Bad predictors of severity, how to predict who will have a bad outcome. There are multiple scores, and it is very important to be able to select a score because we have limited resources, not because we don't have we cannot pay, but selection availability was a major thing during the pandemic of many resources. You could develop your own, such as what we did in Oman. We did our own, which called ICU score, and that helped us in triaging the patient who require ICU care. So let's start with these clinical presentations. These are the common presentation where we see in COVID patient. The first case is for a severe COVID infection. The second is for a critical patient who has been with you. You treated with all the different modalities, but the progress required intubation. And then the last one is a patient with comorbidities plus milder disease. What actions and what therapies you should offer them. Different guidelines, multiple, regional, national. Basically, they divide into hospitalized and non-hospitalized patients. And this slide was shared by Dr. Jamila as well. And I wanted to focus on the importance of post-exposure prophylaxis and early therapy. Very important, because here there is the role of monoclonal antibodies, the antivirals. If we look into therapy of severe disease, once the patient progresses, really, there are few things that you could offer them. The immunomodulator therapy. Most importantly now, we are focusing on pre-exposure prophylaxis. Your patient is at risk of developing COVID. They did not receive the vaccine, or they are at risk, they have been exposed and they are immunosuppressed. How to protect them? So most of the guidelines, the current guidelines, focus on these two areas. I will start with 3 important guidelines because they are recent, and believe me, guidelines for therapies for COVID, every day there is a new recommendation. Very difficult to catch up with all what is happening. So the ones that are highlighted in red are the recent changes. As Dr. Jamila said, for mild diseases, we use the antiviral. So currently there are 3 antivirals. We have the IV antiviral, the old ones, remdesivir, and we have 2 novel oral antivirals, nirmatrelvir and molnupiravir. These are both oral, and also we have the monoclonal antibodies. Once your stage passed to severe, immunomodulator therapy, and you can still use, if the disease is early, you can use the antiviral remdesivir for shorter duration than the previously recommended. There is also an alternative, which is a JAK2 inhibitor called baricitinib, with the steroids and remdesivir for patients who are rapidly requiring oxygen therapy or they are on non-invasive ventilatory support. For critical, the options are limited to immunomodulator therapy. Now, outpatient, PrEP, pre-exposure prophylaxis with monoclonal antibody, the Evoshield, a new antibody, monoclonal antibody. For post-exposure prophylaxis, the only one that has been studied is Regenon, the drug that Mr. Trump took. This is how you can remember it. But there is an issue with it. It does not work for Omicron. So if you have Omicron, it does not help you. Now, the second set of guidelines that are recent, they are National Institute of Health of US, and they are similar to IDS, but the key thing here on the right side, the anticoagulation issue. And this was another major change or major conflict among the hematologists, ID, and others who are caring, and intensivists. So currently the recommendation is to stick to prophylactic dose. You don't need to give therapeutic dose as we used to do earlier, except if you have a documented evidence of pulmonary embolism. A nice thing about NIH, they give you order of preference, which one you start first, second, third. And that's good for us and when we develop our own national guideline. The last guideline I want to share is WHO. And WHO, there is a difference between the definition of severity. The definition for severity, the standard that we use, including the NIH and IDS, is when the oxygen saturation is less than 94%, while WHO is taking less than 90%. And that's an important difference as well. It's similar to the guidelines that were mentioned earlier. You see the role of thromboprophylaxis, oxygen therapy, steroids, interleukin-6 inhibitors, tocilizumab, and JAK2 inhibitor, baricitinib. Conditional recommendation for using of Regenon, again, Mr. Trump, monoclonal antibody, in sick patients who are seronegative. So you need to check their antibody test. If they are negative, they are in ICU, you could give them that. And also conditional approval for using of monoclonal antibodies and oral antiviral in condition where patients have less severe infection, but they are at risk of progression and they are not hospitalized. No for antibiotics. Key thing we learned from this pandemic, stewardship is very important, and antibiotic have zero role. Now, all this intervention, Dr. Jamila said prevention is better than cure. You look into what's the risk reduction of this intervention, mortality risk reduction. 33% recovery trial with dexamethasone. 4 to 9% absolute mortality risk reduction in with tocilizumab. And with some of the monoclonal antibody, 0.6% or 6% absolute reduction in seropositive negative hospitalized patient. So if we want to implement these guidelines, going back to our patient, the 65-year-old who had severe illness, hospitalized, early phase, what does the guidelines, the 3 guidelines that I present, tell you? They all agree on role of dexamethasone, the role of IL-6 inhibitor, tocilizumab, but they differ in the antiviral, remdesivir. The data for remdesivir, the recent data comes from this particular study that was published in New England Journal of Medicine that showed in patients who require oxygen, rapidly oxygen, or they are on high flow oxygen, if you combine remdesivir together with baricitinib and the steroids, the outcomes are better in terms of time to recovery, and there was a tendency for also decreased mortality. From here comes the guidelines in the last in the first two guidelines for use of remdesivir. So what about severe and very critically ill patient? There is no role currently, and this came from WHO, large solidarity trial, as well as Discovery, which is a UK trial, looked into this particular drug. It was a chaos, and we had to have our own. Waiting for guidelines would be a problematic. A drug like remdesivir went through indicated, non-indicated, and then again indicated. So it's very important that we conduct our own research, because this is the way out. Usually guidelines also take a very long time till they come up and they are distributed. The last patient, outpatient therapy is very important in early disease, so non-hospitalized, ambulatory, early phase. What does the guidelines say? You can see that there is a difference in the selection of the monoclonal antibody and the selection of oral antiviral. But in mujmal, eventually most of them, they go around these two. Why the change in remdesivir? It seems WHO is not in favor because of their solidarity trial, but a recent publication looking into remdesivir early into illness in non-hospitalized patient showed that giving it for 3 days as an outpatient setting for patient with mild disease in a randomized published trial showed a reduction of progression and risk of death by 0.7%. So a total reduction comes to around 88%, which is significant. So where we are going, as Dr. Jamila said in her talk, we have a way forward, and the moving should be to the anticolonal antibodies as well as the oral antiviral. You don't want patient to present to you sick and ill, critical. At that times, there are limited options. We need to identify the high priority groups, and this is in the aim to reduce infectivity transmission also, and minimize the burden on the health system. Monoclonal antibodies are way to go. There are novel antiviral interventions. They bind and neutralize the virus. They are recombinant proteins derived from B cells of convalescent plasma of patients or vaccinated individuals or mice. How do they work? They work beautifully to block the entry or fusion of the virus into the cell. They also can, if the virus enters into the cell, like this infected cell, it can get lysed by activation of macrophage attack complex and by lysis and phagocytosis. So it works very beautiful. The drawback for it requires infrastructure and efficacy dimension with the mutation and new variants as well. And in this slide, I'm just showing you that we have different combinations of monoclonal antibodies. Currently, the two that are working are sortivimab, and this is widely used in the Kingdom of Bahrain, and the newer one, which is called Evoshield. Evoshield is an important drug that has been recently added. It's an IM, 2 injection at the same time, given as a pre-exposure prophylaxis, and it prevents getting infection for up to 6 months, with a 77% reduction in the progression to disease. These are the indication who should get PrEP in order for you to decide. Basically, your immunocompromised patient, because their response to vaccine is very limited. That's why they get the priority. Molnupiravir is another important novel drug. It's an RNA against RNA respiratory viruses. What does it do? Once it's a prodrug, once it gets into the blood, it gets phosphorylated into the cells, and then it gets into the viral genomes of the virus. It leads to mutations and then catastrophe and killing that virus by mutation. The evidence has been good for outpatient, not for inpatient. The problem with molnupiravir is the pregnancy. You cannot use it in pregnancy, in children, and also it should be not given, there should be a protection advice for sexually active individuals because it can be in the system. And remember, it integrates within the DNA. No drug-to-drug interaction and no dose adjustment. The final drug that I want to highlight is the nirmatrelvir, which is a combination of a novel drug, antiviral for COVID, together with ritonavir. So it's a proteinase inhibitor similar to the work of HIV medication. Efficacy is very good, with an 89% reduction of risk of hospitalization. Needs to be given early. These two drugs, the last two drugs, needs to be given in the first 5 days of illness. The problem with it, multiple interaction with drugs like contraceptions, anything that is cytochrome 450 inducer. And it should be adjusted in renal impairment and not recommended for severe renal impairment or severe hepatic impairment. So factors used in determining what is your recommendation, and those were highlighted in Dr. Jamila's talk as well. Clinical efficiency is very important. Convenience, logistic, do you have the infrastructure? What kind of infrastructure you have? Availability to the general population. Are you dealing with children? Are you dealing with pregnant ladies? Drug interaction. And what's the predominant variants of concern in your country? Is it Omicron? Is it Delta? What kind of Omicron? Is it B1? Is it B2? Because the efficacy change as per what predominant variant you have. And this is just to compare the efficacy of these 4 drugs that I think are important way forward. We take Paxlovid, efficacy of 88%. The events, drug versus placebo, effect 0.8 versus 6.3%. You take sortivimab, 85%. You take remdesivir, 87%. And the least is molnupiravir. So take-home points and messages. Therapy for COVID-19 depends on host and the severity. There is no one-size-fits-all. You have to think of all the factors that we have discussed early in my presentation. As a concept, treatment of COVID-19 can be broken into antiviral and immune-modulating therapies. And when we talk about antivirals, there are a spectrum or number of them. Monoclonal antibodies and oral antivirals address unmet need and timely treatment of COVID-19, and they are really a way to go because we don't want people to get infected. We know vaccination are not 100%, so patients who are exposed or individuals exposed, immunocompromised, these are the category of patients we want to prevent them from getting the infection by providing these drugs. Guidelines are evolving rapidly. Every day there is a new thing. And finally, research. We have to conduct our own research. And these are the opportunities when we meet in these regional conferences that we build a network, we share data, and we also come up with a consensus guidelines for the region. Thank you very much, and that's my last slide.